Excuse me? Yeah, this should be fine. I think it's on. Oh, sorry about that.
Okay, we're going to get started. Good morning. Okay, we're going to get started. Okay. Good morning. My name is Marina Catalazzi, and my pronouns are she, her, and hers. And I want to start by welcoming you to the second annual Columbia Commons Campus-Wide Day of Interprofessional Action, or IPE Day. Today, students and faculty are meant to cross school boundaries and truly understand and learn the skills needed for egalitarian teamwork. And I can think of no better individual to underscore and celebrate the spirit of today than Michael Sparrow. It is truly a privilege and honor to be able to introduce Dr. Sparrow. As faculty in both the medical school and the School of Public Health, I know that Michael embodies the spirit of this day in all of his work. First, let me tell you on paper what makes Michael Sparrow an ideal person to be the keynote speaker for an event today. Professor Sparrow spent 7 years as a litigator for the New York City Law Department, specializing in intergovernmental social welfare litigation. After leaving the practice of law, Professor Sparrow obtained a PhD in political science from Brandeis University. Professor Sparrow is now professor and chair in the Department of Health Policy and Management here at the Mailman School of Public Health. Health Policy and Management, or as we call it, HPM here, has degree programs that include the Master of Public Health, Master of Health Administration, Executive Master programs focusing on health policy management, comparative effectiveness research, and global health, and several other professional development programs. Dr. Sparrow and his team understand the needs of their learners and have created incredible curricula, experiences, and programs that are unparalleled in the arena of policy and management. Professor Sparrow is a national and world-renowned expert in the politics of healthcare, in particular health insurance and health delivery systems for low and middle-income populations, both in the U.S. and globally. Professor Sparrow is the former editor of the Journal of Health Policy, Politics, Policy, and Law, and the author of the book titled Medicare and the Limits of State Health Reform, as well as numerous articles and book chapters. Currently, he has projects that include the rise and demise, studying the rise and demise of most of the nonprofit insurance cooperatives created by the ACA, an analysis of cross-national politics of public health, and an examination of political and policy implications of permitting all Americans to buy into Medicaid. If you take a moment to Google Dr. Sparrow, you will find a multitude of clips of him on MSNBC, op-eds in the New York Times, and other outlets where he makes these vitally important topics and issues accessible in his very clear explanations. Thus, it's no surprise that he is a two-time winner of the Mailman School's Student Government Association Teacher of the Year Award, the recipient of the 2010 Columbia University Presidential Teaching Award for Outstanding Teaching, and the winner of the Core Curriculum Teaching Excellence Award at Mailman. Now, what might not be on paper that makes Professor Sparrow an ideal keynote speaker is what I'm going to be able to tell you now. I'm the director of the General Public Health Program, which is focused on accelerated public health students, many of whom are dual degree MD and PhD students. I remember the first time that we were in a meeting together about accelerated students, we were on two different sides of an issue regarding students, and as you can imagine, I was a little intimidated. I left the meeting with a deep sense of gratitude to be able to call myself his colleague. It was clear that he was knowledgeable about the details of the curriculum that his students were engaged in, and while he had a strong opinion, he was extremely open to discussion, novel approaches, and what I had to say. There's no doubt that if there was an argument to be won, he would have done so easily. Instead, he approached the discussion in the way that I've come to expect of Professor Sparrow, with a deep respect for education, an openness to the ideas of others, and a fierce commitment to assuring that the learning that his students are engaged in while here at Mailman is steeped in social justice. Perhaps more importantly, in the years that I've worked with Dr. Sparrow, I've come to appreciate his kindness and humanity. The loyalty and reverence of those who have learned from him and work with him is not surprising. He remembers details of conversations and is the first to send an email or lend a supportive word in times of celebration or challenge. These are the things that truly set him apart from his peers. As a qualitative researcher, I always find the words of others to more deftly reflect what I'm trying to convey. So I'm going to leave you with a quote from one of Professor Sparrow's former students, who is now adjunct faculty here at Mailman and researches and writes about race, gender, and economic equality. When I told her of my good fortune of introducing Professor Sparrow, she immediately texted, you know what a strong impact he had on my education and career. He's the only professor I had through my undergraduate and graduate studies who could give a 3-hour lecture about health policy without slides or notes and keep everyone in the room rapt. This was really a reflection of his deep knowledge and incredible passion for his work and teaching. And so it gives me great pleasure to introduce Michael Sparrow. He's going to be presenting the keynote this morning, Health, Politics, and Social Justice, the Impact of the 2020 Presidential Campaign, without slides.
Thank you so much. Thank you so much. Thanks, Marina. I have to say, I've been here at Mailman for 25 years. I've been here a long time. And that, I think, was the nicest introduction that I think I've ever received in 25 years. So really, thank you very much. And it's my pleasure and honor to be here today chatting with you about health politics, social justice, and the 2020 presidential campaign. Is this loud enough? Could everybody hear me in the back? Okay, perfect. You know, I think we are at a really pivotal moment here in the United States over the future of the healthcare system and over the effort, around the effort to create a fairer, a better, really a more just, a more equitable, and a more just healthcare system. And we're going to see in the upcoming presidential campaign 3 very different views on how to get there. You know, 3 very different views on what the future of healthcare and health policy in the U.S. should look like. On the one hand, we've got Bernie Sanders and Pramila Jayapal and others who are basically saying, let's take this window of opportunity that we believe we have, let's get rid of the for-profit motive in healthcare, let's get rid of private health insurance, let's expand Medicare and provide Medicare to everybody in the country. This is sort of a window of opportunity. It's a bold moment to be bold. Let's sort of go ahead and try for that. That's path number A. Path number B, you've got sort of more moderate Democrats and some Republicans, but primarily Democrats, including Nancy Pelosi and other leading Democratic and other folks who are running for president here in the United States, who are saying, you know what, let's not try to, you know, upend their system completely. Let's try to stabilize and shore up the Affordable Care Act, and maybe let's let people buy into or expand a little bit the Medicare and Medicaid program. Let's adopt more of an incrementalist approach. Let's get there step by step. Let's not let the perfect be the enemy of the good, and let's just sort of go for this more incremental route that fits our path better here in the United States. So that's sort of strategy or path number 2 that's out there right now. And then you've got President Trump and the Republicans who are basically saying, you know what, elect us, let us take over the House of Representatives again in 2020, and we will again repeal or try to repeal the Affordable Care Act. We'll replace it with some undefined but spectacular health care proposal, you know, that will really deal with and what the president, in fact, I just, this morning, just 5 minutes ago as I was coming over here, I was reading President Trump's tweets from last night, you know, and President Trump said, everybody agrees Obamacare doesn't work, premiums and deductible far too high, really bad health care. Even the Dems want to replace it, et cetera, et cetera. And then he says, you know, Republicans will always be the party of health care and will support people with pre-existing conditions. And I think what President Trump was sort of focusing on there, and what he will be continuing to focus on, is sort of the high out-of-pocket costs that people face, and his view that the problem is really the ACA, and we should be getting rid of the ACA and trying to replace it with something else. So you've got these 3 fundamentally different views about where we should be going in the healthcare arena. Now, I have to confess at the beginning, and then I'll come back to this, and I don't know if this is a real confession, but I'm in that sort of middle category. I'm in sort of the incrementalist category. I'm in the let's not go for Medicare for all right now. Let's try for sort of, you know, shoring up the ACA, you know, letting people perhaps buy into Medicaid, letting people perhaps buy into Medicare, focus on some other things. But at times when I talk to colleagues, when I talk to students, when I talk to others, I almost feel a bit guilty at times. I think to myself, well, you know, am I really, am I being sort of, you know, a little hesitant here? Am I not sort of going for the gold? I mean, is there really an opportunity? Is there really a moment to sort of replace what is largely, in many respects, a 2-tier health insurance or healthcare system in the United States Is it a mistake simply to be an incrementalist? Should I and should others like me, who are teaching health policy, who are, chairing departments of health policy and management, who are working with students and who are working with colleagues on these kind of issues, is it a mistake for people like me, to sort of be a little more cautious here and a little more tentative about what's possible and what's appropriate and what we should be trying for? And so that's really a little bit of the conversation that I want to have with you today, not so much about me, but about whether or not, what's the right path forward for those who really do think that it's incredibly important that we have a better, a fairer, and a more just health insurance and healthcare system in the United States. So the way I want to do this is I want to do sort of 4 things relatively quickly each one. But first, and for those of you who've had me in class, the first couple will be a little bit of a repeat. But first, I want to talk a little bit for about 10 minutes or so about how we got here. How did we develop the health insurance and the healthcare system that we have here in the United States? How did we get this sort of mixed public-private system that we have? So that's number 1. Number 2, I then want to talk about sort of the problems that still exist. What are the gaps? What are the main problems that still exist in our health insurance system and healthcare system today? That's number 2. Number 3, I want to go into a little more detail on those 3 different paths that I just talked about, sort of the Medicare for All path, the incrementalist path, and sort of the repeal of the ACA and try something else path. And then number 4, I want to sort of talk with you about what really is the best path forward, arguably the best path forward as we think about the 2020 campaign and as we think about where to put our energy and where you should be putting your energy. And I want to try to leave time, and I've got my watch, there's no clock here. I'm going to really try to keep an eye on my watch to make sure that there's a little bit of time for you to contribute to this conversation and sort of add your voice as well, because that's what this day is really about. All right, that's my plan. All right, so first, how did we get here? How did we get here? How did we get the health insurance system that we have today? Well, this story really goes back to the 1920s, early 1930s. There was no health insurance in this country in the 1920s and 1930s. It simply did not exist. What we did have in the 1920s and 1930s was we had a growing hospital industry. We went from about 35,000 hospital beds in the United States in the year 1900 to about 950,000 hospital beds in the year 1930. So there was this unbelievable boom in the hospital industry. Then what happens? Is the stock market crashes in 1929, and the country is plunged into an economic depression. So all of a sudden, we've got this incredibly growing hospital industry hit all of a sudden by the economic depression. And folks who've been going to the hospital, we finally hit that tipping point in the mid-late 1920s where people started saying, okay, it's safe for me to go to a hospital, and we're building hospitals, and that's where I can get care. All of a sudden, people stop going to the hospital because they can't afford to pay the bill, because they're paying the bill out of their own pocket. Now, at that point here in the United States, it was considered both unwise and actually unconstitutional for the federal government to get engaged in health and welfare and economic policy more generally. There was no way that the federal government was going to come in and try to help these hospitals that were in trouble. So instead, hospitals started going bankrupt. Hospitals just couldn't make it, late 20s, early 1930s, around the country. It was what, you hear a lot when you hear about the Depression, you hear a lot about farms going bankrupt, you hear about banks going bankrupt, you hear about people unemployed, very high rates of unemployment. But you don't hear a lot about the fact that the hospital industry was devastated by the Depression. It was a brand new industry, and all of a sudden it's devastated. So what happened? Well, again, there's a story we could talk about at great length if you want, but the bottom line is the hospitals and the doctors, in an effort to secure their own financial viability, they developed a health insurance system. They developed, in the early 1930s, the hospitals developed Blue Cross, the physicians developed Blue Shield. Basically, the hospitals said, if you pay a premium to us, we will give you some prepaid health care. We will say to you, give us 50 cents a month, give us $1 a month, give us $1.50 a month. And in exchange for that $1.50 a month, you can come to our hospital and get 20 days, 21 days of care without paying anything else. That's the first private health insurance we had here in the United States, and that was the beginning of the private health insurance system in the United States. Around that same time, the for-profit insurance industry, which was not in healthcare at that point, but the for-profit insurance industry, which was selling life insurance, automobile insurance, workers' compensation insurance, home insurance, these other kinds of insurances. Well, at that point, the for-profit insurance industry says, you know what? If the hospitals could create Blue Cross, and if the doctors could create Blue Shield, then we, and if they're not even insurance companies, and there's a depression going on, and government's not involved, so if the hospitals and the docs can do that, and we don't have government interference, maybe we, the for-profit insurance industry, should go into the health insurance world as well. And so we evolved in the 1930s this sort of two-pronged health insurance system. First came the hospitals and the docs with Blue Cross Blue Shield. There was a nonprofit insurance system designed to basically allow the hospitals and the docs to survive financially during the Depression. And then along come the for-profit insurers and say, hey, don't forget about us. We know the insurance business. We can get engaged here. All right, so you have in the 30s the development of this industry. The 1940s, Harry Truman says, how about national health insurance? Let's forget the hospitals. Let's forget Blue Cross. Let's forget private health insurance. Let's go for national health insurance. But that goes nowhere at all. Nowhere at all. There's too strong interest group opposition. There's cultural opposition. It's just not happening here in the United States in the 1940s. As a result of that, what we see is we see employers in the 1940s and 1950s, employers say, you know what, maybe we should actually pay for the private health insurance of our employees. That'll be a perk of employment. That'll be a perk of employment. Now, by the 1950s, the economy is booming. The economy is booming, and so employers are competing for employees. So they say, maybe we'll give them this fringe benefit, private health insurance. And you know what? The government says we will assist the employers in giving them this private health insurance. We will enable them to use the tax code to have it be to the benefit of both the employer and the employee if the employer gives private health insurance. So if Columbia University spends $30,000 a year on health insurance for me and my family, that doesn't count as income to me. I don't have to pay taxes on that. Plus, Columbia University can write off the cost of it. So that in this period, we go from having the private health insurance system that began in the 1930s, Blue Cross and the for-profits, to now government using the tax code to encourage employers to pay for health insurance for their employees. And so in the 1950s, that system becomes mainstream. And by the end of the 1950s, early 60s, over 65% of all Americans have employer-sponsored private health insurance, either because my employer provides health insurance to me, or my spouse's employer provides health insurance to me, or my parents' employer provides health insurance to me. So this really becomes phase two of the health insurance system in the United States. Phase one, 1930s, Blue Cross for-profit starts. Phase two, 1950s, employers say, we'll pay for it. So we'll have an employer-sponsored private health insurance system. Phase three, early mid-1960s. Early mid-1960s, 1965, Congress enacts Medicare and Medicaid. Medicare and Medicaid are a public insurance safety net, for those who don't have access to employer-sponsored private insurance. And so we developed this kind of two-track system in which even today there's about between 150 and 160 million Americans who get health insurance either through their employer or their spouse's employer or their parents' employer. So a little bit over half of all Americans get health insurance through this private health insurance, through this employer-sponsored health insurance system. And then we have about another, 100 million Americans who get health insurance either through Medicare or Medicaid, where the public insurance system here in the United States evolved into the safety net for those who didn't have access, the elderly, the disabled, the poor, for those who didn't have access to private employer-sponsored system insurance. And then, of course, in 2010, we get the Patient Protection and Affordable Care Act, which says, you know what, we are going to build on both of those wings. We're going to build on the public wing, i.e. expand Medicaid, expand public insurance, but we're also going to build on the private wing, try to make private health insurance more available and more affordable. And so that's where we are today. We've got this system in which a little over half the country gets private health insurance through their employer or a family member's employer. A good chunk of the rest of the country gets public insurance, publicly funded insurance, either through Medicare, Medicaid, or the Affordable Care Act. And we've got this dual system, public and private. And I have to say to you, the fact that we have a dual system doesn't make us unique internationally. Most high-income countries in the world have a mix of public and private insurance. We have a different kind of mix. In many other countries, high-income countries, the public system is sort of available, providing a basic level of insurance for everybody, and then the private system supplements or complements that so that the more wealthy folks buy sort of extra insurance through the private. But everybody's got this mix of public and private, just about everybody, including us. All right. So that's a little bit, a very sort of 15-minute version of how we got the system we have today, this sort of historical evolution which kind of fit the pattern of health, sort of fit sort of the American culture, I guess you would say. So that's point one. Point two, what are the main problems in the system today? Well, we could spend an hour talking about the problems in the system today, but let me just point out three problems in the system today that I think really need to be dealt with. Problem number one, there still are, even in 2019, in the United States, there's about 10% of the country that still lacks health insurance. There still are 30 million or so people on any given day who don't have health insurance. Now, who are those people? Many of them are actually eligible for insurance. They're eligible for Medicaid. They're eligible for subsidized coverage under the ACA, but they don't enroll. Maybe they don't enroll because they don't know they're eligible. Maybe they don't enroll because they're worried about their immigration status. Maybe they don't enroll because they think it's too much of a hassle. But there's a good chunk who are eligible but not enrolled. That's category number one. There's another large chunk who don't enroll because they're not eligible because of their immigration status. Either they're undocumented or they're in some status which makes them nervous about applying. And so there's another large chunk that worries about health insurance and access because of the immigration status. And then there's a third category of folks who live in states like Texas or Florida, which have simply not expanded their Medicaid program under the Affordable Care Act the way they could have and should have, and so they're not eligible right now. So you've got folks who are eligible but not enrolled. You have some folks who still are not eligible for publicly financed coverage and don't have access to private coverage. And then you have these large swaths of immigrants, both documented and undocumented, who are uninsured today. So that's problem number one, that we still have to, in order to have a more just, a fairer, a better health insurance system, we should not have 30 million uninsured in the United States. Problem number two, the majority of Americans who have health insurance in the United States are facing higher and higher and higher out-of-pocket costs. The deductibles that even those with insurance have to pay are going up, 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 thousands of dollars a year before their insurance kicks in, at least for anything other than, a wellness visit once a year. And this isn't just the case for those who are buying on the insurance marketplaces under the ACA, the 150 million folks who have employer-sponsored coverage are paying for coverage that comes with very high deductible policies as well. Myself, here at Columbia University, I have a high deductible health insurance plan. You know, I have to incur a few $1,000s of health care bills before the plan really starts kicking in. Now, I'm lucky, and people like me are lucky, in that attached to my high deductible health insurance plan is a health savings account, so I can have a certain amount of money taken out of my salary each month to use that to cover some of the costs of those services. But most people with high deductible health insurance policies do not have associated or affiliated health savings accounts. And so those high deductible plans, the cost of the premiums, the cost of the copays, and certainly the cost of these deductibles deters people from getting health care they need. We still have insured people who are not coming to the doctor, who are not getting the tests they need, who are not getting the service they need because they're worried about the cost, even if they have insurance, much less the 30 million who don't have insurance. So that's another big problem I think we need to deal with here in the United States. And then a third problem, which is connected to the first and the second, is there still is a whole host of disparities in access to care. I mean, there really still is something of a two-tier system in the United States. There are services and procedures and physicians who basically are available only to those with the best and the most expensive commercial insurance. And then there are services and procedures which are available to everybody else. And so we still have that bit of a two-track system. All right. So we've got this sort of unique evolution that we had here in the United States of this sort of public-private mixed system. We have these remaining problems, lots of uninsured, underinsured, rising out-of-pocket costs, and ongoing inequities and disparities in the system. What are the options for dealing with it? Well, I mentioned them very quickly at the beginning, but let me run through them a little bit more carefully now. Bernie Sanders, if he was standing here, he would say, you know, in effect, back in 1935, 34, 35, 36, when we first started moving toward an insurance system that relied heavily on for-profit insurance companies, that was almost, I guess you could say, the original sin of our healthcare system. That was the beginning of the real problems that we had and have. That was the big mistake, to incorporate into healthcare sort of the for-profit motive, to incorporate into healthcare for-profit insurance companies, to incorporate into healthcare for-profit pharmaceutical companies, for-profit hospitals, for-profit, you know, systems more generally. That should not be that should not be part of healthcare. There should be a fundamental, basic, minimum right to healthcare that everybody in the country has. We shouldn't have this for-profit motive. So therefore, what Bernie Sanders is saying, and what others are saying on the presidential trail and elsewhere, is we need to remedy that original sin. We need to take the for-profit motive out of healthcare. We need to eliminate the private health insurance industry in the United States. Eliminate it. And we need to replace it with an expanded, single, public insurance program, Medicare, that gives sort of an expanded set of benefits, because Medicare now has a relatively limited set of benefits. Expand the benefits and put everybody into that Medicare program. Put all 150 million who now have employer-sponsored insurance, put all 75 million who now have Medicaid, put all 8-10 million who buy health insurance individually, put everybody into that single system. We won't have a two-track system anymore. There'll be no for-profit motive in healthcare anymore. We won't be paying premiums anymore. Instead, we will substitute sort of a progressive tax system which taxes the wealthy, to pay, you know, primarily taxes the wealthy to pay for that system for everybody. So that's the Sanders approach. And that's the Sanders proposal at this point. In response to that, the incrementalists say, you know what, that's not, you know, there's both a political and a policy response to that. The political response to it is, it's not going to happen. The interest group opposition is just too strong. The hospitals and the insurance companies and the pharmaceutical companies and the doctors and the employers, the political opposition, the interest group opposition is too strong. The cultural opposition is too intense. We are a very divided country, and we're divided primarily on the role of government. And basically, in America, to say we're going to get rid of the private health insurance system, we're going to take those 150 million Americans, take away their private health insurance, put them in a public system, that's going to generate fierce, 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 fierce cultural opposition. The institutional obstacles are too strong. In order to make that happen, not only would Bernie Sanders or some similar Democrat have to be elected president, but the Democrats would have to have 60 senators, 60 votes in the United States Senate, and that's simply not going to happen. So there's the interest group opposition, there's the cultural opposition, there's the institutional obstacles, there's the fact that, it's a $3.5 trillion industry, healthcare right now, that's been growing and growing and growing and building off this now 90-year history. And you can't just throw out this 90-year history. Some people would say, you know what, Medicare beneficiaries themselves aren't going to be very happy about this because Medicare beneficiaries view Medicare as their program, that their special program, that they've earned, by paying into for the last 30, 40, 50 years, whatever they happen to have paid into that program. And they don't want the whole country now in their program, at least large numbers of them won't want that. And then, the incrementalists also say, and you know what, this notion of public-private distinction sort of goes a little too far because, you know what, in our the public programs we have right now sort of are filled with private sector engagement. I mean, over 40% of current Medicare beneficiaries now join Medicare Advantage plans, private Medicare managed care plans. Over 80% of Medicaid beneficiaries now receive their health care through the private managed care industry. So what's public and what's private? Does it really matter in 2019? Where does the difference really lie? Instead, say the incrementalists, let's sort of shore up the Affordable Care Act. Let's stabilize that law that the Republicans in Congress and the White House have been trying to undermine for the last couple of years. And let's allow people access to Medicare or Medicaid. Maybe let's lower the eligibility age for Medicare from 65 to 60 or 55. Maybe let's let people buy into Medicare if they want to. Maybe let's let people buy into Medicaid if they want to. But we have over 90% of the country covered right now, say the incrementalists. Why why take on that battle right now when you're just going to lose that battle and potentially lose the presidency because of it? So that's the incrementalists' route. And then, of course, path number 3 is the Republican proposal right now. The Republican effort to basically say, you know what, Americans, there are problems with the healthcare system. Out-of-pocket costs are too high. In fact, President Trump referred to that in his tweet this morning, or last night, whenever he wrote it. I mean, the out-of-pocket costs are too high. But the cause of the problem is not what the Democrats are saying it. The cause of the problem actually is the ACA. The cause of the problem is actually excessive government involvement. Too much government, too much ACA, too much regulation. What we really should be doing, say the Republicans, is deregulating the system, allowing and engaging for more, quote-unquote, competition and markets and personal responsibility. And that's the path toward a more just, more appropriate, better healthcare system in the United States. So we have these 3 very different paths that you're going to hear about a lot over the next several months during the presidential campaign. You're going to hear the Democrats debating among themselves who's being bold, who's not being bold, is this a time, is this a window of opportunity that's potentially being lost? You know, is this sort of a progressive, quote-unquote, progressive moment in the United States that we could take advantage of and should be taking advantage of, and that we shouldn't simply let this moment slip away? Or is it silly and counterproductive to try to to sort of fight the whole healthcare fight again in 2021, assuming the Democrats take over the presidency and perhaps Congress as well? Or what's going to happen if the Republicans not only control the White House again in 2020, but if the Republicans again control the Senate and maybe even the House? So how do we play that out? So what's the best path forward? Let me just throw out a couple of ideas myself, and then I want to ask you what you think. And I want to get your input. As I said before, my own view is we really ought to be focusing on these three problems that I identified. Problem number one, we still have 30 million uninsured. Problem number two, out-of-pocket costs are simply too high for even those with insurance. And problem number three, we have to deal with access and disparities, inequities in the system. How do we deal with problem number one? I actually think the way to deal with problem number one is to stabilize the ACA, is to let people buy into Medicare and Medicaid, and to move incrementally. I don't think the way to deal with the problem of 30 million uninsured in 2019 is to upend the system for 300 million and start over again. You can disagree. I mean, this is the kind of conversation I think we have to have. But that's what I would argue for is sort of the best path in terms of coverage. Problem number two, out-of-pocket costs. Now, this is really a big problem. People are still, even with insurance, going without needed health care because they don't think they can afford the bill. Because they can't afford the bill. It's not a question of they don't think they can afford the bill. They can't afford the bill. So what do we do about that? Well, again, to me, there's a big difference. There's a big difference between public ownership, in effect, of the whole health insurance system, i.e., let's have Medicare for everybody, so one big public system, and public regulation of the whole healthcare system. If you look at other countries around the world, if you look at France and Germany and England and Switzerland and Australia and on and on and on, Japan, if you look at other countries around the world, as I said, they almost always have this mix of public and private coverage. But what they have that we don't have is they have a central government, a federal government that regulates the entire system. They may have, Germany has hundreds of insurance companies. They call them sickness funds, but they have hundreds of insurance companies. But the central government in Germany regulates very closely the activity of all of those sickness funds. And to me, the way, the path forward in terms of dealing with high out-of-pocket costs, and also the path forward in dealing with the question of access and disparities, et cetera, in the American context, is to say, you know what, we have this mixed system, this mixed public-private system. We're always going to have this mixed system. It doesn't necessarily make sense to say we're going to take 150 million people, move them out of employer-sponsored insurance, move them out of private insurance, move them into public insurance, start taxing them for that. But what does make sense is for the central government to regulate both the for-profit and the non-profit private insurance industry much more than and much more aggressively than it does now. Much more aggressively. Now, I don't have a simple answer as the best way to do that, and the politics of that are not easy. I mean, I talked about the difficulties of the politics of Medicare for all and the politics of expanding Medicaid and Medicare. The politics, there's one state in the country, for example, the state of Maryland, that regulates what hospitals can charge all insurance companies, whether they're Blue Cross, Aetna, Cigna, Medicare, Medicaid. Every hospital in Maryland essentially charges the same rate to whomever is paying the bill. New York State used to have a provision like that, an all-payer hospital rate reimbursement system. But a number of years ago under Governor Pataki, they got rid of that. That proposal would be opposed, I'm almost certain, by the leadership of New York Presbyterian Hospital and the other big hospital systems in New York, because that proposal arguably would lead to lower reimbursement rates for the hospital. That would arguably lead the hospital saying they're going to have to cut salaries to physicians that they pay. That would lead to a situation where, you know, the orthopedic surgeon and the cardiologist, et cetera, would start earning less money. So, I mean, these are not, you know, it's one thing to say you're for Medicare for all and Medicare rates for all, but you also have to accept that that would mean that the high price of health care here in the United States would come down. It's not so bad, but that would also mean that the high incomes of health care providers would come down. But that's a path that I think we could be talking about and should be talking about to create a better and a fairer and a more just health care system in the United States. But you don't, to get there, you don't need to have Medicare for all. You could keep in place a private insurance system and just more closely regulate it. You can limit, for example, you can limit much more aggressively than we do in the ACA, and you could also do so in the employer-sponsored world. You could limit the percentage of somebody's income that could go toward deductibles and out-of-pocket payments. You can have caps on the out-of-pocket payment, you know, costs that any individual could and should be able to incur based on their income. You could do things through regulation that I think will accomplish many of the same goals of doing things through sort of a quote-unquote revolution of the whole system through Medicare for all, that I think is a better path to go through. So where does that leave me? Again, I wanted to leave at least 10, 15 minutes just to sort of talk about this. But where does that leave me and where does that leave you? Well, you know, healthcare, every one of you is a participant in the healthcare system. You're a participant in the system as a student in a health profession school, whether it's medicine, dental, public health, nursing, you know, whatever school you happen to be in. So you're a future public health or future health professional. Every one of you is also a consumer of healthcare. Every one of you sees the doctor at times, has a parent or a friend or a grandmother or somebody who's battling some serious illness at this point or serious chronic illness at this point. Every one of you, I think, knows the sort of tragedies that happen every day in the American healthcare system. You know the extraordinary things. You know the people whose lives are saved by the extraordinary interventions of the healthcare system. But you also know the tragedies of the system. You know people who go without care because of their inability of pay. You know about the inequities in the system. You know about the disparities in the system. And I think on a day where the focus of the conversation is about social justice, you know, is about how do we achieve a more just, a more fair, a more equitable system here in the United States, you have to say to yourself in part, well, do I think about social justice, you know, and sort of my sort of views on this from sort of a, you know, political philosophy perspective, you know, and we could talk about it. One thing I was thinking of doing in this talk but ended up deciding not to do was sort of saying, all right, you know, there are political philosophers like John Rawls and others who've written theories of justice, you know, and theories of how a society could achieve justice and say, all right, let's think about sort of the ultimate goal. And the ultimate goal is a society in which nobody is treated differently when it comes to health care because of their income, because of their race, because of their gender. You know, that's the ultimate goal. And we are just going to fight to support the effort to get to that goal. And that means we want to go for sort of, you know, a universal system in which everybody is part of that system. Every American is part of that system, because you know what? If we did have a Medicare for all, for example, if 20 years from now, everybody in America was a participant in the exact same health insurance system, and everybody paid in according to their income, and everybody received the same access to care, and everybody received the same services or the ability to get the same services, that would be much closer to a truly just healthcare system. On the other hand, you could say, you know what? What's the best path to getting there? And is the best path to getting there sort of going inch by inch, row by row, you know, minute by minute, incremental extension by incremental by extension? Is that the best path to get there? Or is the best path to get there to basically say, you know what? We committed an original sin 90 years ago with for-profit private health insurance, and we should sort of wipe that out, you know, pull the Band-Aid off in one big tear and start over. I don't have an answer to that question. I think everybody in the room has to answer that question a little bit different, you know, not a little bit differently. Everybody has to sort of think for themselves how they want to answer that question and what they think the best path forward is as we enter this presidential campaign, the best path forward both for the country and what they feel best about, what you feel best about yourself as a participant in the healthcare system in trying to achieve a healthcare system that is better for all. I know I answer that question by saying it seems to me moving incrementally, that's what we've done in this country for the last 50 years, and things are a lot better than they were 50 years ago, and I think we can keep on with that path, and we should keep on with that path. You can answer that question differently. Let me sort of stop here, and I'm really curious just to get some of your feedback and some of your thoughts and input on this idea of what should sort of a person who really is seeking a more just healthcare system, what is the right path forward in the 2020 presidential campaign? So how do we want to do this? Do you want to just maybe people, I can call people, you can just speak loudly, I guess. We have mics, but.
If we need the mic, we have it.
Okay, yeah. Maybe stand up so that everybody can hopefully hear you.
Okay. I can just talk loud.
Okay.
I mean, I'm sort of in the middle ground on that as well. My thoughts are something we just need to think about is if we were to eliminate the healthcare system, the private insurance system, not only would people in the medical field face pay cuts, people who work in private insurance would also face potential loss of jobs and pay cuts as well, and that would be its own issue. And I just think that's something to think about.
Absolutely, and it's interesting, I think, in Bernie Sanders' plan, for example, he has what he calls a transition program for people who would well, two things. One, some of those people would have to simply transfer from the private sector to the public sector, because whether it's in the private sector or the public sector, you still need people to administer the system. So not everybody in the private insurance industry would lose their job, but a lot of people would. And Sanders talks about retraining programs and phase-out funding, et cetera, but the impact financially on millions of people who work in the healthcare system would be quite significant. There's no question about that, absolutely. Yeah.
I think there's another issue that's kind of in play in the 2020.
Maybe could you just so that people can hear, either try to.
I think there's another issue that's in play in the 2020 election that I think really affects this whole process, which is student loans and student debt, because a lot of the reason that physicians expect a high pay cut or healthcare professionals expect a high level of income is because they're going into their professional career with hundreds and hundreds of thousands of dollars in debt. And there are a handful of programs that can help with that currently, but there aren't really that many, and I think that that's also a large issue to pay attention to in the election in terms of how that, what implications that has for people going into healthcare.
So there's no question, and I hope everybody could hear, because it was a very good point. I mean, for those of you who are sort of in the, either in med school or nursing, you know, in one of these schools or public health, you emerge with a large amount of debt, typically. That's one difference between the United States and some of the other countries around the world, and where medical school, for example, is a very low cost, if not free. And that becomes an argument that many physicians will say sort of warrants or justifies the high income, because it's not only the medical school debt, it's the relatively low pay during residency and the first few years of practice until you really build up that practice. But that's exactly one of the reasons why, you know, many in the physician community will end up being sort of feeling schizophrenic about sort of what to do. Because on the one hand, there'll be this impulse to say, well, I want a fairer, more equitable system. I don't necessarily want, the commercial insurance industry and for-profit insurance, et cetera, et cetera. On the other hand, I've got a certain expectation, and maybe, again, think about it, and I'm making these numbers up, but right now you might have a situation where a orthopedic surgeon or, et cetera, or a neurosurgeon, whatever, is making, I'll just make up a number, $500,000 a year. And under a system which was sort of a Medicare for all, or the rates were sort of basically Medicare rates, or close to Medicare rates for all, they would probably receive almost a little around half of that. So you might say, well, all right, $250,000, $300,000 a year, that's not a bad salary. People can live on, most people don't get to live on $250,000, $300,000 a year. But you're telling someone who is either making $500,000 a year that you're going to have to take, this huge pay cut. That's a big deal. And of course, then that same person, that same doc says, well, geez, not only am I going to have to take this pay cut, but my roommate from college, I've spent all these years sort of, going to med school, trying to do all this good work, doing the residency, et cetera, et cetera, et cetera. My roommate from college, she went to work for some hedge fund or some Goldman Sachs or whatever, and she's now making $8 million a year or something like that, trading paper. Well, I'm now being asked to take a pay cut, doing surgery. So I think these are really complicated, tough questions. Yeah.
Off of that, so in my opinion, you don't go into medicine for the money to start with. And then the second point is CEOs of these nonprofit hospitals are making upwards of $10 million a year. And if that cuts, they're not going to be getting a pay cut. It ultimately hurts the rest of the system.
So a couple of points that were made there, again, for those of you who couldn't hear, which is that I'm not sure about the $10 million a year upwards, but maybe some like the HCAs. Does he? Okay. I didn't know. I'll ask Steve next time I see him. But I don't know. But I do know that CEOs. One of the points that I think is a really important point that you just made is that there's a real question about sort of this notion that we should get rid of the for-profit system in healthcare because the nonprofit system in healthcare is truly this sort of do-good nonprofit. We're not in it in for the money kind of system. When, regardless of how much the CEO of NYP makes, there's no question that the nonprofit hospital system is not, sort of the big nonprofit academic medical centers basically operate not all that much differently from the big for-profit hospitals around the country. So and I think you could say the same about insurance companies. You could say the same. So what is exactly the difference between nonprofit and for-profit when you're in a $3.5 trillion industry? And what does that mean for the physician who is entering the field because not, as you said, not for the money, but because they're committed to doing this, but is graduating with $250,000 worth of debt or whatever it is, is trying to raise a family and live in an expensive city like New York or Boston, et cetera, which is where the large majority of specialists operate these days. These are really tough questions. Way in the back.
Could you speak to the incrementalist camp attitude towards reining in healthcare cost inflation? Because some of the appeal, I think, to Medicare for All is there's some logic to collective bargaining with pharmaceutical companies or economies of scale, and I worry that in an incrementalist system, we just can't have healthcare be a sixth of GDP, given that we get relatively mediocre results of our healthcare system.
Well, first of all, when it comes to healthcare cost containment, the public system does a lot better than the private system right now, for better or worse. The Medicare and Medicaid, pay docs a lot less. And the cost, if you look at the cost of an MRI or if you look at the cost of any procedure, Medicare and Medicaid will pay a lot less. So one of the appeals that Bernie Sanders and others will say about Medicare for All is that by using, in effect, the public insurance rate. And it's interesting because the commercial insurers use Medicare rates as the basis for what they're going to charge, but they say, basically the hospitals say, instead of paying instead of charging 100% of Medicare, hospitals in the United States charge on average about 175 or 180% of Medicare. So they charge almost twice the Medicare rates. So I actually think the incrementalist approach, it's not so much, again, public versus private. I think to the extent that you can, where I see you sort of needing to get a handle on healthcare costs in the United States isn't so much whether you have Medicare for all or private insurance, it's whether or not the government, the central government, begins to regulate prices in the private sector. I mean, the reason the price of healthcare is so much higher in the United States than other parts of the world, there's two main reasons. The first reason why the cost of healthcare in the United States is almost double that of most of the rest of the world is the price we pay for everything in healthcare is just way higher than anybody else. The second reason is, interestingly enough, we go to the doctor less often and we spend less time in the hospital than our counterparts elsewhere, but our utilization of high-tech services is, the volume of high-tech services is way higher in the United States than anywhere else. So our P for price and our V for volume of high-tech is way high. Other countries regulate the price and they regulate the volume. And they do that whether they have a public system or a private system. So to me, the way you begin to get a handle on healthcare costs, and I'm not saying this is easy to do politically, because this gets back into the same dilemma that we've been talking about before, which is that we may have a $3.5 trillion healthcare industry, but every one of those dollars is somebody's income. You know, it's not just a question of shifting income and prices. It's a question of actually cutting prices. And that, I think, requires regulation. That requires regulation.
Maybe one more.
Okay. Last question. Maybe turn around so I can hear you, but others can hear you too.
Okay. I'm a dental student, and in 2 weeks, 1,000 dental students and dentists will be marching in D.C. to advocate for a couple issues. And one of the things that we're advocating for is repealing the Ferguson Act. I guess this is a question and a comment. So I guess the act, just background, the act exempts private health insurance companies from antitrust laws. And I was wondering, you know, it's kind of crazy that they have that exemption, and if that act does get repealed, would that affect private insurance premiums to make it more competitive, or?
You know, there's a whole, I mean, what time is it? It's 10:31. That's a really complicated question. You know, the role of sort of the antitrust, and in fact, physicians and others basically, you know, have been battling this whole question of antitrust for a long time. I think that law doesn't prevent the federal government from doing anything. And I think you see this debate playing out over accountable care organizations and the ability of physicians and dentists and others to sort of come together as groups to sort of negotiate prices and so forth. My own bottom line on that, and I hesitate to get into this too much because it's a complicated issue, my own bottom line is I think it's, you know, fine to think about repealing McCarran-Ferguson, but I don't see that as pivotal to sort of improving the healthcare system here in the United States. I think what's pivotal is for the central government, for the federal government, to take a sort of a much more aggressive role in regulating the system, which they can do whether there's a McCarran-Ferguson or not. But I'm happy to follow up with you on that sort of separately in a separate conversation in which we talk about that. Thank you all very much, and I hope you enjoy the day. Thanks for coming. Enjoy the rest of the day.
I mean, for me, I get part, like, I see what you're saying about, like, the problems with overhauling and doing single payer, but for me, the single payer is